Good evening, everyone. Welcome to today's webinar on World of Anti-Cancer Drugs. So the speaker of the day is Dr. Navonil Dutt. Dr. Navonil Dutta, MBBS FIC, is an accomplished medical educator and a clinician with a passion for simplifying complex medical concepts through evidence-based, case-oriented learning. Dr. Navonil has completed his MBBS from Bankura Saminil Medical College and earned a fellowship in cardiology from Mediversal Academy, securing a 100% score in fellowship examination. He also holds a postgraduate diploma in rheumatology. Prior to this, doctor gained a valuable clinical experience as a postgraduate student and a resident assistant in the Department of Pulmonology Medicine and Critical Care at AIG Hospitals, Hyderabad, actively participating in patients' care, case decisions, and multidisciplinary rounds. He also worked on a frontline during the COVID-19 pandemic as a frontline medical officer, providing inpatient care and teleconsultation services. His academic achievements includes receiving the Best Undergraduate Poster Award at Consciousness Jaipamir and a Best Alumni and Faculty Award from Mediversal Academy. He also has actively participated in several national conferences and CMEs in internal medicine, rheumatology, and pulmonology. Over to you, doctor.
Thank you. Thank you for the introduction, Kiran. Good evening to everyone present here. And I hope you all are doing well. We're meeting after a very long time. And I'll be starting off with the webinar right away. I hope I'm audible and visible clearly.
You're audible.
I'll be sharing my screen and I'll be asking for a confirmation one more time. Just give me a moment. Okay. I hope my screen is visible.
Yeah, yes, doctor, it is visible.
Yeah, perfect. Okay. So it'll be a very short and a crisp webinar. Okay. Unlike my other webinars, which usually goes on for a really long time, this is going to be an exception. This is going to be a really short and a crisp webinar because it's more of a theoretical webinar where we are just going to discuss about the major advancements, the major drugs that we are going to deal with. And some of the drugs we are going to talk about the mechanism of actions and the predominant uses that we are going to. So it's more of a pharmacological webinar, one which is information heavy. So for the ones who are, wanting to get the maximum benefit out of it, I would recommend you to keep the PDF with yourself and repeat and reread this and review it multiple number of times. And, keep viewing cases in your ward postings, or if you're working in an oncology setup, that's the best thing that you can do. You can always review your clinical cases with the drugs that are given here. And you can also add on to your knowledge based on the baseline that is being provided here. So that is going to be the ideal thing. And of course, as we are talking in this moment right now, there's going to be a lot of advancements that are going on. There's going to be many other molecules that are being targeted in the upcoming future. And I'm very sure that most of the cancer molecules, most of the cancers which were once, thought to be a curse, is surely something that won't be seen with that perspective in the upcoming years, and it will be seen of more as a curative disease rather than something which leads to a high mortality in the community. So hoping for that, I think we are already moving in that direction. Very recently, a drug for pancreatic cancer has come up, which has shown excellent results in human and animal, in animal and human clinical trials. It has shown excellent efficacy, and I'm very sure more such trials are going to happen, and we are going to have a lot of beneficial drugs coming up in the recent future. So with that note, we'll be starting off with our slides, and yeah. So the first thing that I'll be trying to talk to you is I'll be taking up doubts after the session because it's going to be a very crisp session. So I'll be taking up doubts entirely after the session. So I'll be requesting you to focus here. And one more request from my end is please keep your microphones on mute. Please do not, create an unnecessary chaos in between the session because that disrupts the flow of the session both on bilateral ends. So that's a request from my end. I hope you will cooperate with me on with respect to that. Okay, so coming to this now, just give me a moment. I need to sort this out. How can I do this? Yes, yes. So looks a very dreadful diagram, but it's a very simplified diagram from one of the finest and the simplest books, First Aid. So I wanted to go by that. We have this phases of cell cycle, which go in this order of G1, S, G2, and M. S being the synthesis phase of DNA, and G1 is the phase where the cellular content duplicates. That is the 2N content of DNA happens in the G1 phase. G2 is more of a phase where the DNA that is synthesized in the S phase undergoes a checkpoint where we are checking whether there is any repair required of the DNA that has been synthesized. And the M phase is the one where there's mitosis happening. So that's the basic overview of a cell cycle that happens. And let's also have this baseline knowledge that all of this is happening in the presence of certain molecules, which are called cyclins. And cyclins are based on certain proteins, which are known as kinases. And hence, these protein complexes are combined together to form, to call as what we know as CDK or cyclin-dependent protein kinases. Right. And these cyclin-dependent protein kinases are also molecules that we'll be studying in the subsequent slides, against which targeted anti-cancer molecules have been, directed for anti-cancer therapies. So coming back to this slide where we have these four phases in order: G1, S, G2, and M. And we'll be first talking of the drugs which are cell cycle independent, which means that these drugs can act at any point of the cell cycle. And when I talk of that, we first talk of the platinum compounds. And when I talk of platinum compounds, I'm predominantly talking of cisplatin and carboplatin. I'll talk of predominantly the one prototype that is cisplatin. When I talk of cisplatin, I want you to know that are you all able to see the pointer? Is my pointer visible? Can I get some responses? Is my pointer on the screen visible?
Yes, doctor.
Yeah, perfect. Okay. So when I talk of cisplatin, I want you to know that cisplatin is the most nephrotoxic. It is the most ototoxic, which means that it can lead to hearing loss. And it is also most emetogenic, which means that it has the maximum potential to cause nausea and vomiting. Most patients who are on cisplatin will be often complaining of this nausea and vomiting. Some of them complain of an early nausea and vomiting. Some of them will complain of a delayed nausea and vomiting. Okay? Now, how do I prevent the nephrotoxicity that is caused by cisplatin? It is by this compound called amifostin. Okay? Now, ototoxicity. This ototoxicity, however, is due to the damage of the outer hair cells, which are the sensory organs that are located in the cochlea. So ototoxicity, however, cannot be prevented to a larger extent. However, we can tackle with the emetogenic potential of cisplatin. The early emetogenic potential, the early nausea and vomiting that is caused by cisplatin, can be prevented by giving the 5-HT3 antagonists, that is the ondansetron kind of drugs or the ondem kind of drugs that we commonly know. Or the delayed nausea vomiting can be prevented by what we commonly known as the pitand group of drugs, that is the NK1 or the neurokinin peptide 1 antagonists, that is the aprepitant group of drugs. Okay? Now, coming to alkylating agents. In alkylating agents, we will have quite a number of these compounds, which is busulfan, we have nitrogen mustards, we have nitrosurias, we have procarbazine, we have dactinomycin. So we have temozolomide. So we have a number of these molecules under alkylating agents, and I'll be going one by one into these. So when I talk of these molecules, when I talk of these alkylating agents, I want you to know this, that these alkylating agents, although they are cell cycle independent drugs, the predominant effect of these drugs are found in the steps of in the time when the mitosis has just happened, and during the time when the cellular content is duplicating, that is predominantly in the G1 phase, but before the G1 phase is starting, that is in the quiescent stage or the G0 phase of the cell cycle. Okay, although they are called the cell cycle independent drugs, they predominantly are acting on the G0, the quiescent phase of the cell cycle. Okay, now coming to certain anti-metabolites. Anti-metabolites are the ones who are going to have a role in the inhibition of the DNA synthesis that happens in the S phase. And under these, we have the set of drugs. Under this, cladribine is the only drug which is a cell cycle non-specific anti-metabolite. All the others are, however, cell cycle specific, and they are specific to the S phase. Okay? So we have these drugs like cytarabine, we have 5-fluorouracil and capecitabine, we have hydroxyurea, we have methotrexate, we have pentostatin and thiopurines. Now, coming to this, let us know a few things when we talk about these drugs. When we talk about cytarabine, it has a particular side effect of cerebellar ataxia. We can even remember this by the name of cytarabine. It has these two letters as C and A that can lead to cerebellar ataxia. So cytarabine can cause cerebellar toxicity in the form of ataxia. Cerebellar toxicity. C is cerebellar toxicity. C is cerebellar toxicity in the form of A for ataxia. Okay? Now, 5-fluorouracil and capecitabine. हमारे पास 5 उंगलियां है and F for foot. So 5 fingers in the hand and F for foot. So 5-fluorouracil and capecitabine can lead to something which is called hand-foot syndrome. I'll be showing you the images of these diseases in the next slide. Okay, coming to hydroxyurea. Hydroxyurea is something that is also used in sickle cell disease. It has been found to be very effective in reducing the episodes of sickling. So it's got also its uses in beyond anti-cancer therapy. Methotrexate is something that has got a very beautiful use. I mean, it is both used as an anti-cancer drug where it is acting as an anti-metabolite. It is also being used as an anti-inflammatory drug in the treatment of conditions like psoriasis and rheumatoid arthritis. So the mechanism of action of methotrexate in the treatment of anti-cancer as an anti-metabolite and anti-inflammatory in rheumatoid arthritis is actually a little different. So what happens is in anti-cancer drugs, as an anti-cancer drug, methotrexate is going to inhibit the dihydrofolate reductase enzyme DHFR. So when dihydrofolate reductase enzyme is inhibited, it is inhibiting the formation of the proper formation of active folate. And when active folate is not being formed, what is happening is UTP is not being converted into UMP, and uridine is not being converted into thymidine. Let's make it simpler in that way. Uridine is not being converted into thymidine, and we know that uridine is something that is present in RNA, and thymidine is something that is present in DNA, right? So if uridine is not being converted into thymidine, so DNA synthesis will not occur properly, and that is how methotrexate is acting as an anti-metabolite in the S phase synthesis inhibitor. That is its role as an anti-metabolite drug as an anti-cancer drug. However, if I talk of methotrexate as an anti-inflammatory drug in rheumatoid arthritis, it is in the increase. It is acting there by inhibiting this enzyme called AICAR transformylase. So AICAR transformylase is inhibited, thereby which the adenosine levels inside the joint is being increased. When the adenosine levels inside the joint are being increased, the increased adenosine level is what is exerting the anti-inflammatory action. So that is exactly how in RA it is acting as an anti-inflammatory drug, whereas in a setting of malignancy, it is acting as an anti-metabolite. But in both of these cases, one thing is definitely common, that it is going to lead to depletion of folate. And whenever the folate stores are being depleted, it might manifest in the form of vitamin B12 deficiency or megaloblastic anemia or macrocytic anemia. Let's say macrocytic, not megaloblastic, macrocytic anemia, which is why replenishing the folic acid or the folic vitamin B12 becomes extremely vitamin B12 and vitamin B9 for that matter becomes extremely important. So methotrexate, wherever it's given, whether it's given as an anti-cancer drug or whether it's given as an anti-inflammatory drug in RA or in psoriasis, we have to always keep in mind that we are going to supplement it with folate, that's vitamin B9, or we have to also check the levels of vitamin B12. And if the levels of vitamin B12 are concomitantly low, we have to give both vitamin B9, that is folate, and vitamin B12, that is cyanocobalamin, simultaneously. Okay, coming back to 5-fluorouracil, it is going to inhibit this enzyme called thymidylate synthetase. So thymidylate synthetase is being inhibited by both 5-fluorouracil and capcitabine. And as I said, it's going to lead to something called hand-foot syndrome as a side effect. And apart from this, thiopurines and pentostatin are something that is going to act via they're going to inhibit the synthesis of purines. So that is how they are going to act as DNA synthesis inhibitors. Okay. Apart from that, we also have enzymes known as topoisomerases. And what are these topoisomerases going to do? They're going to decrease the tension of the DNA strands. So the DNA strands that are being synthesized, synthesized in a helical pattern, and they will be twisted around each other in this fashion. Now they have to be synthesized in a method by which there is a minimum tension in between these two strands, and that is being taken care of by the enzymes topoisomerase. There are two types of topoisomerase. There's topoisomerase 1 and topoisomerase 2. I know most of these things might sound a little too much over the head, but then the topic is such that I cannot be dealing into the depths of topoisomerase 1 and 2. For this, you have to go back to your biochemistry classes of first year, or you have to pick up a book of genetics and read the simple phases of cell cycle and the DNA replication. I mean, if I'm given a chance maybe someday to speak about the phases of cell cycle and replication from that perspective, I can always take a session on that. But today's discussion is going to be restricted to the drugs, which is why I am going to restrict my discussion to the drugs. So I'm really sorry for the people who are not going to align very much with the terms of topoisomerases. But definitely I'll try to make sure that the team comes up either with me or with an esteemed speaker who can talk to us or talk to you all about the different enzymes that are involved in DNA replication, and give more insights about the target molecules that can be further used as anti-cancer drugs. Okay, coming back, so topoisomerases, we have topoisomerase 1 and we have the topoisomerase 2. And how I usually remember it is I can do something. That's how we say it, right? Like I can always do it. So when I say I, it's me always as one. So anytime a drug is ending with the word can, it is going to be a topoisomerase 1 inhibitor. You write 1 in Roman as I, and there are always two of a story. So anytime a drug ends with the word side, it is going to be a topoisomerase 2 inhibitor. So that's how I remember these two drugs as anytime anytime the drug ends with a side, that's an etoposide or a terliproside. Any story has two sides, so it's a topoisomerase 2 inhibitor. And irinotecan and topotecan are drugs which have a can in it, and I can do it. So it comes as a topoisomerase 1 inhibitor. So that's all about antimetabolites and topoisomerase inhibitors. Coming to the G2 inhibitors mainly, and the M inhibitors, G2 and M inhibitors. So remember, G2 and M is the phase where I talked of the DNA repair mechanisms, and M is the phase of mitosis. So this is the place where you will have two drugs acting. One is the bleomycin and the other is anthracyclines. And when I talk of anthracyclines, you have specifically two kinds of drugs. The one is doxorubicin and donorubicin. Okay? So these are the kind of drugs which have ruby in their name, donorubicin and doxorubicin. So these ruby kind of drugs, let's remember it this way, that ruby is a girl. And I'm sorry to all my female colleagues and my female doctors and practitioners here, but let's remember it as a mnemonic that Ruby is a girl, and Ruby is a girl who keeps on breaking hearts. So Ruby sabka dil todti hai, for people who understand it in Hindi better. So Ruby dil todti hai, so Ruby breaks hearts, and that is why doxorubicin and donorubicin are the two drugs which usually lead to cardiotoxicity. And how do we prevent the cardiotoxicity that can happen with these two drugs? That's doxo and donorubicin. It is with an antioxidant molecule which is known as dexroxazine. So dexroxazine is what we usually prescribe for these patients. That's the spelling, dexrazoxane, DEXRAZOXANE. So that's in summary all the drugs that we are talking of. So We talked of platinum compounds as cisplatin. We talked of how they're nephrogenic, nephrotoxic, ototoxic, nausea, vomiting being their side effects. Early nausea, vomiting prevented by Ondem, and the late nausea, vomiting prevented by the aprepitant, which are nothing but NK1 antagonists. We talked of the antimetabolites, which are going to act in the S phase. We talked of cladribine being a non-specific antimetabolite. We talked of cytarabine having cerebellar toxicity in the form of ataxia. We talked of 5-fluorouracil and capcitabine in the form of hand-foot syndrome. We talked of it inhibiting the thymidylate synthase. We talked of hydroxyurea being used also in the treatment of sickle cell anemia, where it inhibits sickling. We talked of methotrexate. We talked about its mechanisms, dual mechanism of action. One mechanism of action where it was inhibiting, just give me a moment. Yeah, it's dual mechanism of action. One mechanism where it was acting as an anti-inflammatory drug in rheumatoid arthritis by inhibiting the ICAR transformylase, thereby increasing the levels of adenosine and acting as an anti-inflammatory drug. We also talked about methotrexate acting as an anti-cancer drug, where it acts as a dihydrofolate reductase inhibitor, thereby reducing the levels of folate. When folate levels are less, it inhibits the conversion of uridyl to thymidine. So when uridyl to thymidine conversion doesn't happen, DNA synthesis does not happen, because uridyl is a component of RNA and not a component of DNA. So we talked about these drugs. Then we talked about topoisomerase 1 and 2 inhibitors. Under one, I talked of the CAN drugs, irinotecan, topotecan. I talked of the topoisomerase 2 inhibitors, where a story has two sides. So etoposide and telibrocyte. So these are the two drugs. We talked of anthracyclines and we talked of bleomycins. Now, finally, let's talk about the microtubule inhibitors. We know that whenever mitosis happens, so this is the phase where microtubules polymerize, and the polymerization of microtubules is extremely essential for the steps of mitosis to get for the steps of mitosis to happen, because whenever the microtubules are polymerizing properly, that is exactly the step which is going to precede the cellular content duplication, because that is exactly the step that will lead to the G1 phase happening in the cell cycle. I mean, that is, in fact, that is the step after which the cells will enter into the quiescent state. Some of the cells will enter into this G0 phase or the quiescent phase, and other cells will enter quietly into the cell duplication phase or the G1 phase. So we have these microtubule inhibitors in the form of taxanes and vinca alkaloids. When I talk of vinca alkaloids, I'm predominantly talking of vincristin and vimblastin as the two drugs. And I'm talking of taxanes, I'm predominantly talking of paclitaxel drugs. So how the mechanism of these drugs is very simple to remember. When I talk of taxanes, let's remember that taxes stabilize the society. So what these taxane group of drugs do, what these paclitaxel group of drugs do, is they hyperstabilize the microtubules. Now remember, stabilization is a good thing, but hyperstabilization is a very bad thing. Polymerization of microtubules will only happen when they'll break and then they'll rejoin together to polymerize together. But if you hyperstabilize the structure of the microtubules, they will not be able to undergo a disjunction and a non-disjunction. That leads to hyperstabilization of the microtubules, thereby not leading to polymerization. So that is what the taxanes do. So taxes stabilize the society, remember it, and thereby you can remember that taxanes lead to taxanes lead to hyperstabilization, and vinca alkaloids cause disruption of the microtubules, thereby leading to incomplete polymerization. Some other group of drugs like colchicine, mebendazole, and griseofulvin. These three group of drugs, although they are not used in anti-cancer therapy, they are also microtubule inhibitors. Colchicine has a good role in the prevention of gout. Mebendazole is used as an antiparasitic agent, and griseofulvin has been used as an antifungal agent. So these are the three drugs which have non-anti-cancer uses, but can be but they have the same mechanism of action in the form of microtubule inhibition. Okay, so having talked of this, let's quickly talk about the side effects of certain drugs that we talked here. So when we talk of anti-cancer drugs, most of us are scared about the effects of bone marrow suppression that occurs with these drugs. But there are three groups of drugs usually which spare the bone marrow, and that's what we are discussing here: the bone marrow sparing drugs. Just give me a moment. Yeah. So when we talk of the bone marrow sparing drugs, we have vincristin, naam mein hai Christ, So Christ ka banda hai, someone who is a child of Christ, Christ will take care of the fact that the bone marrow is spared. But unfortunately, vincristine, although it spares the bone marrow, it crushes the nerves, thereby leading to peripheral neuropathy. Also, I want to tell you this, when I talk of taxanes and paclitaxel, paclitaxel is another drug which leads to severe peripheral neuropathy. In fact, it's used in breast cancer in most patients, and paclitaxel has been shown to have one of the worst cases of peripheral neuropathy that can happen. Okay, bleomycin is something that can lead to presentation called flagellate dermatitis. Again, a picture that I will be showing you in the subsequent slide. L-asparaginase is a drug that was historically used for ALL, that is acute lymphoblastic leukemia, and it has a side effect of pancreatitis. This is a very interesting slide called drugs causing pulmonary fibrosis. If you can clearly see, all of these drugs have some or the other kind of a vehicle in their name. Cyclophosphamide has the name of cycle in it. Busulfan has the name of bus in it. Bleomycin, let's leave bleomycin for a while. Carmustine has the name of car in it. Methotrexate has the name of truck in it. And amiodarone has the name of drone in it. And all of that have one thing in common. A drone, a truck, a car, a bus, and a cycle have all one thing in common, that they blow the horn. So they blow the horn, that is bleomycin. All of that has one thing in common. They blow the horn, and for blowing something, you need the lung. So all of these lead to pulmonary fibrosis. So what are the drugs that can lead to pulmonary fibrosis? All of the vehicle wala drugs, cycle, bus, car, truck, drone, all of these will blow the horn. So these will lead to pulmonary fibrosis. One more thing, with cyclophosphamide, that is a nitrogen mustard drug, it can lead to something called hemorrhagic cystitis. This is due to a compound that is produced by cyclophosphamide, which is called acrolein, acrolein. Acrolein is a compound that is produced by cyclophosphamide that can lead to hemorrhagic cystitis. That is predominantly seen in the pediatric population, and it however can be prevented by giving a drug called Mesna. You can remember it as Mesiha. Mesiha is someone who protects. So Mesna can prevent hemorrhagic cystitis. And in case hemorrhagic cystitis has developed, you can treat it by steroids. Another thing with cyclophosphamide that I want you to know is I usually would prefer not giving cyclophosphamide in a young female because of the high risk of gonadal toxicity, because it can lead to a high degree of gonadal toxicity that can occur in the young males and females. So that is another side effect that is related to cyclophosphamide. Okay. Coming to certain images. So I talked of flagellate pigmentation. So there's the flagellate pigmentation that is found in the use of, as a side effect of use of bleomycin. This is 5-fluorouracil and capecitabine, leading to the hand-foot syndrome. And as I told you, it inhibits the enzyme called thymidylate synthetase. This is hemorrhagic cystitis. This is the gross pathology imaging. And this is due to the metabolite of cyclophosphamide called acrolein. It can be prevented by Mesiha, and it can be treated with steroids if it happens, if it can be treated with steroids. But prevention is better than cure, as we say. So you can give Mesna and you can give active oral hydration. Okay? And coming back, what else do we have? Okay, so this is, as I said, the mnemonic for pulmonary fibrosis. You have busulfan, you have carmustine, you have cyclophosphamide, you have methotrexate, and you have amiodarone. So these are the drugs that can cause pulmonary fibrosis. Now, we come to, we have mainly talked about the cell cycle inhibitors. We've talked about the drugs that were involved in that process. Just give me a moment. Yeah, we have talked about the cell cycle inhibitors. We have talked about the drugs that were involved in that process. And we'll be now talking about the targeted anti-cancer drugs. When I talk of the targeted anti-cancer drugs, I'm going to talk about certain molecules, which are the targeted molecules against which the targeted anti-cancer therapies have been developed. The first one is the tyrosine kinase. Tyrosine kinase happens to be one of the first, discoveries against which we found out the historic drug for CML, that is chronic myeloid leukemia. As you know that in chronic myeloid leukemia, what happens is there is a translocation of BCR-ABL, and this BCR-ABL is basically a 922 chromosomal translocation. That is, chromosome number 9 usually contains the ABL gene, and the chromosome number 22 contains the BCR gene. You can remember it very easily. The ABL is the first letter is A, and BCR, the second letter, I mean, the first letter of, yeah, let's keep it simple. 9 and 22 are the two chromosomes. A pehle aata hai, to ABL will go to 9 and BCR will go to 22. It's as simple as that. So ABL BCR is the translocation. I mean, BCR ABL is the translocation of 922, and that is the translocation that led to CML, because it led to an increased activity of the tyrosine kinase enzyme. And what is this tyrosine kinase? It was actually a growth promoting signal. It was a growth promoting signal transduction pathway. So what this tyrosine, what the anti-cancer therapy was targeted as, it was targeted towards decreasing the signal transduction pathway of the tyrosine kinase pathway, where we could decrease mm, the the tumor burden of CML that was happening. And imatinib was the drug that was first, discovered. Imatinib mesylate was the first drug that was discovered in this regard as the first historical first line tyrosine kinase inhibitor for the treatment of CML. Then later it also got approved for c-KIT mutations, which involved the pediatric GIST, that is gastrointestinal stromal tumors. Apart from that, we also have other, tinibs like lapatinib, sorafenib. So when I talk of lapatinib, it is used in breast cancer. It is not the drug of choice, remember. Sorafenib, however, is the drug of choice for hepatocellular carcinoma. And we have something called PARP inhibitors. What is PARP? It is poly ADP ribosyl phosphate inhibitors, and they are, they are being inhibited by the drugs called olaparib and rucaparib, and they have a role in the use of breast cancer. I mean, they are being used in breast cancer. How you remember it, as you can clearly see, PARIB, so poly ADP ribosyl, so PARI, poly ADP ribosyl, and B for breast cancer. They are being used in breast cancer. You can remember it that way. I was talking of cyclin-dependent protein kinases, which help in the continuation of the cell cycle between G1S, G2, and M. And under cell cycles and the cyclin-dependent protein kinases, we have cyclin-dependent kinase 4, we have cyclin-dependent kinase 2, we have cyclin-dependent kinase 6. We have cyclin-dependent kinase 4 and 6 inhibitors that have been developed in the name of cyclibs. So you can remember cyclibs inhibit cyclins. So cyclibs inhibit cyclins, and palbociclib again is, palbociclib again is a drug that is being used in breast cancer. We have certain monoclonal antibodies which are being used in breast cancer. Among them, the monoclonal antibodies, how do you know that something is a monoclonal antibody? If something has a MAB in the suffix, MAB in the suffix, it's going to be evident that it's a monoclonal antibody. Now, if along with MAB it is having a TU2 in its name, it's evident that it's going to be used for a tumor, like cetuximab, rituximab. Okay, so cetuximab is used for C4 colorectal cancer. Rituximab has been used for non-Hodgkin lymphoma. It has been used for chronic lymphocytic leukemia. Okay, we have another thing called trastuzumab and pertuzumab. Again, they are having two in their names, which means they are being used for certain cancers. And we can remember this as, again, we trust people. As I said in the last slide, as I said, Ruby was a girl who kept on breaking hearts, but we still kept on trusting her, right? So in Hindi, we would say that रूबी दिल तोड़ती रही, पर तू फिर भी उसको ट्रस्ट करता रहा. पर तू, so pertuzumab, तू फिर भी उसको ट्रस्ट करता रहा. Trastuzumab led to cardiotoxicity. So again, doxorubicin and daunorubicin have ruby in their name. That leads to cardiotoxicity, which can be prevented by desroxazine. And trastuzumab and pertuzumab have, again, per2 and trastuzumab. So trusting someone, again, is breaking the heart. So cardiotoxic, and again can be used in breast cancer. So that is something. Just give me a moment. Hello. Hello. Hello.
1 second, doctor. Doctor, you can unmute now.
Yeah. Hello. Hi
Yeah, you're
everyone.
audible,
Sorry,
doctor.
there was a power fluctuation at the
Ah.
end of Mediversal, so this session got muted. I mean, paused for a while. I'm really sorry for the inconvenience. I just want to know, uh, till the point where this happened, was I audible and visible? Quickly in the chat box. Quickly in the chat box. Okay. I just want to know one more thing. I was explaining about remembering this trastuzumab and pertuzumab, as how to remember them, as they cause cardiotoxicity. Was that audible to everyone? Yeah, it was audible. Okay, fantastic. Okay. Okay. So I can carry it forward from there, right? It's perfect. It's perfect. Yeah. Okay. I can see someone kindly explain about anti-angiogenesis agent bevacizumab. Okay. First of all, okay. Uh, okay, fine. I'll just quickly talk about bevacizumab here, although it was not there in my slides. Um, Bevacizumab is something that has been used in metastatic colorectal cancers and non-small cell lung cancer, especially in the it can also be used in some forms of renal cell cancer as well. Now, the point of using bevacizumab is because it is acting as an anti-VEGF agent. What bevacizumab does is it will bind the circulating vascular endothelial growth factor A, and thereby it will prevent it from binding to its receptors. Vascular endothelial growth factor receptors that are present on the vascular endothelial cells, bevacizumab is going to just prevent the binding of VEGF to VEGF receptors. Okay? Now, before the VEGF is going to reach the endothelial cells, bevacizumab is going to act extracellularly and it's going to neutralize that VEGF molecule. So it is going to act as an anti-angiogenic drug. It is not a direct cytotoxic, or it's not a direct anti-cancer drug. Okay? When I talked about so therefore it is used usually in combination with chemotherapy. It is not a direct chemotherapy. It is not a direct chemotherapeutic agent. It is not a direct chemotherapeutic agent. It is something that has been used in combination with chemotherapy because it is something that prevents neoangiogenesis. Okay? Is that clear? Your name is Guest. I'm not able to understand what your real name is. See, the entire point is Dr. Guest. I'm not really sure what your name is, but if you could please let me know if your doubt is answered. Because if you just asked me about the use of bevacizumab, that is mainly the use of bevacizumab. Although I mentioned bevacizumab being used in non-squamous cell lung cancer, let me tell you, it is used very cautiously because it can lead to life-threatening hemorrhages as well. Uh, Now, coming back to the base crux as to why bevacizumab is used in combination with chemotherapy, is because, say, suppose I give 5-fluorouracil, or say I use carboplatin or paclitaxel as a chemotherapeutic agent, it will rapidly kill the tumor cells. Now, whenever the tumor cells are being killed at the same point of time, bevacizumab is going to inhibit angiogenesis. So the tumor cannot form the new blood vessels, and the existing the tumor blood vessels, they are also not able to function properly for the tumor to receive the blood supply. So what this leads to is the tumor is basically devoid of its blood supply from its new angiogenic blood vessels, and chemotherapy that is being existingly given, it is going to kill the tumor cells. Okay? That is why bevacizumab is, I mean, the most common regimen where bevacizumab is used in is FOLFOX or FOLFIRINOX regimen that is used in metastatic colorectal cancer. It is also used in ovarian cancers as well, where we can combine it with carboplatin, we can give it with paclitaxel as well. Okay? Okay, somebody was talking about CDK4 and 6 inhibitors. Yeah, that is palbociclib. This is Dr. Sabia. Dr. Sabia, that is palbociclib. Any more doubts? Omalizumab? No, 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 no. See, my dear, I just told you any MAB is any MAB is a monoclonal antibody. Any MAB does not mean that it's an anti-cancer drug. Any MAB means it's a monoclonal antibody. Monoclonal antibodies can be used in cancer, it can be used in rheumatoid arthritis, it can be used in IBD, it can be used in in multiple diseases it can be used. There are some monoclonal antibodies which are used in cancer. I'm only talking of the monoclonal antibodies which are used in cancer. As as Dr. Rimjim says, that omalizumab is an anti-IgE molecule that is used in the treatment of, it's a biological monoclonal antibody against immunoglobulin E. Mechanism of action, rituximab in pemphigus. Yeah, I have told you the mechanism of action of rituximab in pemphigus and skin disease. Okay, so the point is, in rituximab, in pemphigus, rituximab is acting differently. Rituximab is an anti-CD20 molecule. So what this causes, CD20 is expressed by B cells. Okay? Whenever CD20 is being inhibited by rituximab, it is going to lead to the destruction of B cells. And this is by a phenomenon which is called ADCC, that is antibody dependent cellular toxicity. This will lead to apoptosis of B cells, destruction of B cells. Okay? So this will destroy the desmoglein 3 antibodies and the desmoglein 1 antibodies, which are the predominant, the antibodies which are autoantibodies which are responsible for the development of pemphigus vulgaris and foliaceus. I mean, vulgaris ke liye desmoglein 3 is responsible, and foliaceus ke liye desmoglein 1 is responsible. So by depleting the CD20 positive B cells, I am preventing the formation of new plasma cells. Yeah, perfect. I think against omalizumab, the explanation given by Dr. Imjim is perfect. Any other question? Can I take it forward? Any other questions? Perfect. Good to go. Yeah. Okay. Good. Good. Oh, I realized my video was off all this way. Okay. Sorry. Okay. Coming back. So we talked of CDK4, 6 inhibitors. We also talked of the monoclonal antibodies. Okay. Now, let's talk of this thing. Why on earth am I not able to? Yeah. Okay. So now this is a certain immune interaction which is happening between a T cell and a tumor cell. Trust me, this is actually an interaction that happens between a T cell and a normal human cell. Bhul jao for a while that it's a tumor cell. It's a normal human cell. Okay? What happens is, okay, let's for a while forget this image. Suppose this is a kala hit. You can all see this is a kala hit. Okay? This is a T cell. I'm a normal cell. When do you think that this Kala hit will work? Only if I'm a mosquito, right? So this will not work against me. Why? Because every time it comes in front of me, it will look at me and realize, this is a human being. It will not work against me. It will work against a mosquito, or it will work against the cockroach, whatever it is, right? But which means every molecule or every cell, rather, let's be specific, every cell has certain identification molecules. You can call them as ID cards. Okay? Every cell in the human body has some ID cards, identification cards, by which we know that this is a self cell and this is a non-self cell. Like in India, the ones who are staying in India, we all have a valid voter ID. We have an Aadhaar card. We have a passport for the ones who have it, right? Which says that we are citizens of India. Now, of course, for someone who's in Bangladesh, for someone who's in Syria, for someone who's in Uzbekistan, for someone who's in Sri Lanka, someone who's in, say Maldives, they have other identities which are different from our identities. So naturally, when a Singaporean or a Pakistani or an Afghanistani is going to come to our country, we are going to see their identification and understand that this is from someone, this is someone from another country or another land, not from our country, right? वैसे ही T cells, which are going to be the immune cells of our body, T cells and B cells, who are going to be the major immune cells of the body, they are going to differentiate between self cells and non-self cells based on that identity card. What is that identity card? It's an interaction between the PD1 and PDL1 receptors. Okay? Just remember, it's a PD1, PDL1 receptors. Okay? Now, cancer cells someday came to know this. They were like, kya baat hai? Once T cell sees that passport and sees, there is a PD1 on the normal cell and there is a PD1 PDL1 interaction, T cell does not attack those cells. So it decided to cheat and it decided to create a fuzzy PD1 and PDL1 card, just like this, so that it could show such a interaction to the T cell and escape the immune system. This process, where a normal T cell or any cell of the body is checked by the T cell for a PD1 PDL1 interaction, is called an immune checkpoint, and invading the immune checkpoint or evading the immune checkpoint acts as a mechanism of cancer. So we found out drugs which would target this PD1 and PDL1 receptors, or the interaction between these two molecules, so that we could make anti-cancer therapies for them. And this is the name of these drugs. We can remember it by this mnemonic: nivolumab, durvalumab, avelumab, atezolizumab, ipilimumab, semipilimab, and pembrolizumab. Out of this, I will tell you, pembrolizumab is one of the major changes that happened, and pembrolizumab is one of the major inventions that actually changed the way that we looked at immune checkpoint inhibitors. So you can just remember the names of these drugs, and as I said, there's no specific use to this. These are used in variety of cancers based on the requirement, based on what is the patient profile. But knowing the mechanism of the drugs is what I wanted you to know, and that is why I've kept it in this slide. Finally, I come as this slide is more of a revision tool. Some additions are there, of course, and a few revisions. So I'm talking of monoclonal antibodies which are anti-cancer. Okay, not the monoclonal antibodies like omalizumab which are used in asthma, not like tofacitinib or baricitinib or other things which are like, other completely a total different setup. I am talking of monoclonal antibodies which have been used as anti-cancer molecules. So when I talk of alectinib and crizotinib, these are used as a target of ALK mutations. And where do we find ALK mutations? We find it in adenocarcinoma lung, that is non-small cell carcinoma of lung. Erlotinib, gefitinib, and afatinib, we find it in EGFR1. that is epidermal growth factor receptor 1 mutations. These are also known as HER1 mutations, human epidermal growth factor receptor 1 mutations. These are also found in non-small cell lung cancer 1 mutations. Imatinib, I talked already, that is tyrosine kinase inhibitor. Bortezomib, that is the zomib group of drugs. The zomib group of drugs are what are the proteasome or the proteasome inhibitors. Whenever we are inhibiting the proteasome, what proteasome does is it is a kachra packing. That's a dustbin of all the toxic wastes. And whenever we are inhibiting that, the cells which are packed with these kachras will now want to undergo apoptosis. Thereby, they will undergo cell death very fast. So these have been used in multiple myeloma, mantle cell lymphoma. Remember that herpes zoster reactivation is a very common side effect of these zomib group of drugs. We have vemurafenib, these RAF group of drugs, dabrafenib, and the encorafenib. The RAF group of drugs are used for the cancers which have BRAF mutations like melanoma. We have hairy cell leukemia. We have Langerhans cell histiocytosis. Okay. Now we come to the palbociclib, which have CDK4/6 inhibitors, which I already talked of. They are used in breast cancer. We have this special group of drug which is called metinibs, that is cobimetinib, that is a MAP kinase inhibitor, which is used in melanoma. Olaparib is again a poly ADP ribosylase inhibitor that's used in the BRCA mutations wala cancers, that is breast, ovarian, pancreatic, prostate cancers. We have the Lisib group of drugs that are PI3K inhibitors. We have the alemtuzumab, which is a very, very important drug that is a CD52 inhibitors used in multiple sclerosis, used in chronic lymphocytic leukemias. I already talked of cetuximab, that is, I talked of TU being there as an EGFR or HER1 mutation. I talked of it being used in colorectal cancer. Brentuximab is used in cancers which have CD30 positivity, that is Hodgkin's lymphoma and anaplastic large cell lymphoma. Vorinostat is used where it acts as a histone deacetylase molecule. We have, these Toclax drugs, which is Obatoclax, which is used as a BCL2 inhibitor. And what is BCL2? It is an anti-apoptotic molecule. So whenever we are inhibiting this, it is helping the cells to undergo apoptosis. That is helping the cells to undergo death. So it is preventing the immortality of the cells, and the cancer cells are usually immortal. So it's preventing the anti-apoptotic nature and making them pro-apoptotic. So that is the summary of the major drugs that I could find out and could, fix it into today's slide. It is a very information heavy slide, but as I said, the more you keep on being in rounds, the more you keep on attending your postings, or the more you keep on reading individually about the cancers, the more you will be able to understand why these mechanism of action works with respect to certain drugs that have been used. And that will actually pave you the path to adding more information to not just the drugs, but also understanding the mechanism of action of how this drug works and the pathogenesis and the pathway of how each cancer is developing, and maybe pave the way for some of you to find out newer drugs and newer drug pathway targets in future. And I'll be very, warmly proud and happily surprised if one of you someday come up here and come up to the world and present a drug where you have worked on, and you have presented it where you have found out a newer mechanism of action. So thank you for hearing me out. It was a crisp session, and I'm very sure that I could target the audience to whatever basic was required for attending this. I'll be switching over to looking at the doubts. I'll be just give me a moment. I'm still trying to figure out. Yeah. Yes. I'll be quickly seeing the doubts, if there are any doubts. Tamoxifen and letrozole are how much helpful to control? Okay, first of all, letrozole is an aromatase inhibitor. It will prevent the conversion of androgens to estrogens. So that is how it will be acting as the drug of choice for a post-menopausal breast cancer. For post-menopausal breast cancer, we'll be using letrozole. Tamoxifen is what we are using in premenopausal breast cancer. Premenopausal breast cancer. Okay? Can we use capecitabine in brain metastasis of breast cancer? Who's this? Dr. Tuan Singh Tang. Can we use capecitabine? Okay, can we use capecitabine in brain metastasis of breast cancer? Okay. Now, coming to your question about using capecitabine in brain metastasis of breast cancer. Well, first of all, I will just say this, that capecitabine is, whenever there's a metastatic brain cancer, the first thing is the blood-brain barrier becomes very, very leaky, right? Capecitabine is converted into 5-fluorouracil because we know that it is a prodrug of 5-fluorouracil. So whenever we are having a brain metastasis where the blood-brain barrier is disrupted, drugs like capecitabine will have clinical activity, but it will not cross the blood-brain barrier very well. So you will have a good, you will have a good penetration. I mean, you will have a good effect, but how much is something that needs to be discussed with a purely an oncologist. That is something that I will not be able to exactly get to you about. Can we get the PDF? Yes, you can get the PDF, Dr. Sabia. Kiran, I think we can share the PDF.
Yeah, I will share it.
Yeah. Yes. For everyone asking for the PDF, yes, you will get the PDF.
We will share it.
Is there any other question that I can cater to? There'll be a feedback form in the end of the session, which Kiran will share. It's my earnest request for to everyone. Please fill up the form and please share your feedbacks. As I say every time, each of your feedbacks are very, very warmly welcome. And we all take very conscious efforts in seeing that each of those feedbacks are addressed very duly. Thank you to everyone. Thank you,
Doctor. Thank you for the wonderful session.
Thank you so much.
So for the participants, I've sent out the form. Please kindly fill the form, and automatically the certificate will be sent to your mail IDs.
Okay, I can see a question from Dr. Twinkle. Dr. Twinkle, yes, exactly. So, yes, okay. I think you typed half of the question and then posted the next part. Yeah. So, lenalidomide is basically a derivative of thalidomide, and what it does is it binds more to this CRBN gene. I think cereblon gene. And I think that is what later leads to this ubiquitin protease pathway activation, and thereby it leads. I mean, that is how it helps in the treatment of multiple myeloma. It is also used in mantle cell lymphoma and myelodysplastic syndrome. Now the point is, what happens is much more than hand-foot syndrome. Hand-foot syndrome se bhi zyada. What happens with thalidomide, first of all, is it is highly teratogenic. So in pregnancy, it is very, very bad. The second thing is it has a very, very high risk of causing myelosuppression and venous thromboembolism. Okay? So that is extremely, extremely bad. But hand-foot syndrome with thalidomide is something that I am not really like aware of, because have you encountered any case of hand foot syndrome with with thalidomide? I am unmuted.
You're audible, doctor. You're unmuted.
Yeah, okay. I think Kiran, I think Twinkle wants to unmute herself. Can you unmute Twinkle for a while?
Sure, I can do that.
Yeah. Yes, Twinkle.
Yeah, you can unmute, doctor.
Yeah, Twinkle, you can unmute
Hi,
yourself.
sir. Good evening, sir.
Hi, Twinkle. Good evening.
Sir, very good information is really help to always. Your
Thank
lecture
you.
is
Thank
always
you so
help
much,
us
Twinkle. Thank you.
to, revise our pharmacology and basic things. I
Thank
have
you.
one patient which is a chronic multiple myeloma. Just
Okay.
done a transplant at least 5 years ago in our global hospital transplant center in Mumbai.
Okay.
After
Okay.
that, he was developing a resection transplant and goes into the myeloma crisis.
Hmm.
Initially, we are treated with the cyclophosphamide and bortezomib, and then switch over to the orally lenalidomide. After
Okay.
starting the lenalidomide, he having a little darkness and there is skin discoloration and very dark nails and dark skin with dark lips. That was not earlier found with my any other patient which were treated with the myeloma with the lenalidomide. So I
Hmm.
want to ask you that it develop a head foot syndrome with lenalidomide or not, because I'm not still
No,
confirmed that it
no,
developed because
no.
of that.
Whatever you are telling me does not look like hand-foot syndrome. Uh, Knee joints are not involved in hand-foot syndrome. Number one, lips are not involved. This looks to be. This can either be a drug-induced reaction. That is one thing that you have to see whether it's a drug-induced hyperpigmentation. That is something that you
Okay.
have to rule out. This because linaclomide does not lead to hand-foot syndrome.
He having typically the discoloration, dark discoloration over the nails of hands and legs and lips, little more darker.
Yes. Is it itchy? Is it pruritic?
Absolutely no, sir. Absolutely no.
Okay. Okay. Is the
It
skin
may be
peeling? Is
developed
the
due to
skin peeling?
cyclophosphamide toxicity.
Okay, the patient is on cyclophosphamide also, right?
Yes, along with that. Huh?
Okay. Okay. Yes. So you have to rule that out also. What is the age
Okay.
of the patient?
Sir, the is 57-year-old male.
57-year-old male. I think nail pigmentation is more associated with cyclophosphamide.
Cyclophosphamide. Yes,
Yes.
yes. Okay. Yeah, yeah.
Yeah,
Thank you
we
so
call it
much, sir.
we call it melanonychia. Melanonychia is something which is very common with cyclophosphamide. Along
Cyclophosphamide.
with it, you will have oral mucosal pigmentation, lips. So
Lips.
this will
Yes.
happen within weeks to months of starting therapy. So that is why I said it is not due to lenalidomide. It is mainly due to cyclophosphamide, because
Oh,
cyclophosphamide will lead to increased melanin production. Because what happens is the melanocytes get destroyed, and when melanocytes are destroyed, the pre-existing melanin that was stored inside the melanocytes, that gets spilled out.
okay.
Okay, so you have to. I think it's more associated with cyclophosphamide.
Okay. Okay, sir. Thank you.
Okay. Thank
Thank
you.
you, sir.
Thank you so much,
Thank
Twinkle. Thank
you.
you.
Thank you.
Okay, thank you. Thank you, everyone. Kiran, thank you.
Thank you,
I'll
doctor.
take leave. Thank you. Thank you so much.
Good evening. Thank you. Thanks a lot.